Okay, I think we will go ahead and get started. Thank you all for being here for this today's Grand Rounds. Today, we're having another session to remind everybody this. I want to thank Sunder and Sabia and the entire division of pulmonary critical care for really getting everything started in terms of making sure that our education continued and that we weren't stopping what we were doing despite the current pandemic. And while we move back towards some sort of normalcy, including with education, that we do so while we're learning much more about the current pandemic and what we can do about it. So we had a couple sessions when we started out focusing on pulmonary and critical care aspects of COVID. Last week, we had a really great session with Claire Phillip and talking about the complications, the anticoagulation or the coagulopathy of COVID. And today we're going to be joined by Ira Bedzow, who's Associate Professor of Medicine and the UNESCO Chair of Bioethics at New York Medical College and the Director of Biomedical Ethics and Humanities Program. I actually found him. I knew that I wanted to do a session on bioethics in taking care of patients with COVID. And so I started out the way I often start when I'm trying to find for a Grand Rounds professor, Grand Rounds guest. I just start Googling and I look on YouTube, and I found this gentleman who has some great titles, and I found an article that he had written on CNN about this exact issue, and then found a YouTube video that showed him talking. So I thought he'd be perfect for us. And in line with what we have been doing, what we'll continue to do, we're going to frame this in a case. And the case is going to be presented by one of our pulmonary critical care fellows. This time it's going to be presented by Sidra Raouf, who's a PGY4 and a first-year pulmonary critical care fellow. And so I want to start off by thanking her so much. Obviously, we all know how incredibly much all of the pulmonary critical care division and all of the fellows have been committed to helping us, and for her to set aside even more time to help out with this and further the education of all of us is incredible. So Sidra, I will let you take over. Oh, before I start, actually, while we're doing this, I think it worked pretty well last week. While we're doing this, if you have any questions, send me a message in the chat box privately. And at the end of this, after the case and the presentation, we'll revisit the case and then have a Q&A session. And I'll use the questions that are submitted to ask Ira and Sidra their thoughts. And so Sidra, go ahead. Thank you.
Okay, thank you, Dr. Cohen. As Dr. Cohen mentioned, that today we'll be talking about some of the ethical aspects which come to question when you are giving treatment to patients with COVID-19. And I'm sure that all of us have had scenarios where we have been thinking what the best decision to make would be. So the way that we planned today's discussion was that first we will go over the skills that are required for making ethical decisions. And once we introduce the skills, then we will go over our case. And then in the end, we will try to apply the tools that we have discussed to the case that we have in question. I would let Dr. Bedzow start with talking about some of the skills that we need to help us make better decisions.
Sure, Sidra, thank you, and David also thank you for inviting me. I'm going to share my screen with some PowerPoint slides that I have. I also want to say that the article that David found with regards to navigating the ethical minefield really had to do with how to create or how to account for the ethics in creating policies and procedures or guidelines for resource allocation. But the skills on how to figure out organizational policies or grand policies are very similar to the skills that you would need at the bedside or in the clinical encounter. They're just applied slightly differently. For example, when thinking about how to create a policy, you need to both think about what the right thing to do is, and then also think about how that decision can be enacted by the organization to turn into good practice, good habits, and good culture. So you're still looking at the decision and then how that decision would be carried out in action. Similarly, clinically or at the bedside, you're also making decisions that necessitate you to think about how to act on that decision properly, given the organization, given the collaborative care team, given the stakeholders that are involved. One looks at a grand picture down to particular instances. The other looks at a particular instance upwards to a more holistic picture. But the skills are very, very similar. So I'm going to go through the skills with you now. I'm sure many of you already have these skills or act on these skills, so I may just be giving language to it. I'll also speak fast because I know we only have an hour and I may not cover everything, but at least it'll give a general insight into what's at stake in terms of ethics to then apply to the case that Sidra will bring. The major thing to think about when we're thinking about ethics, and this occurs, it's so natural, but we tend not to think about the way ethics education is discussed, is ethics shouldn't be seen analogously to medical knowledge, where you know concepts and you know values and you know norms. It really should be seen as skills to develop, which really means that ethical knowledge is important, but it's not enough. You need to know how that knowledge turns into actionable steps to take. So it's not enough to know the definition of patient autonomy. You need to know how patient autonomy plays out in the decision-making and the action that you're going to encounter. In that respect, ethical training is more similar to clinical training as opposed to scientific learning. The second is that how good you are at ethics or the skills that you develop at ethics is not quote unquote objective or standard. That doesn't mean that ethics is relative. What it means is, or that anything that you can justify based on what you want to justify, what it really means is that each person has the personal strengths, limitations, as well as organizational strengths and limitations to be able to act. A first-year resident could do something, may be able to do something or not do something very differently than a third-year medical student or a chief medical officer. So knowing what you can do given where you are in the medical hierarchy, and knowing what you can do in terms of whether you're a good communicator by email or by phone, whether you're an introvert or an extrovert, knowing what you can do will make it easier for you to act on the decision that you end up making. It'll also increase your motivation to act. Many of us like to say that we're idealists. In this world, in real truth, there are very few idealists that will do the right thing at their own expense. There are also very few sociopaths that will just do everything for their own benefit. Most of us fit somewhere within the bell curve in terms of wanting to do what's right and good, while at the same time also not wanting to hurt ourselves in the process. So being able to find how to act on your values and your personal and professional goals in a way that both is effective, successful, and speaks to your own personal wishes as well as professional wishes, you'll be more inclined and more ready to act. So once you recognize that ethics is skills to develop, both in creating policies, both in acting in the moment, you then have to see what those skills pertain to. So I look at the skills of ethical deliberation being two, and the skills of moral action divided into one category, where the skills of moral deliberation really have to do with awareness and analysis. Now, awareness really speaks to the difference between perception and apperception. If you guys have any questions, or if I'm, if you want to interrupt me, feel free, by the way. So perception is really seen as like a passive receipt of knowledge. You open your eyes, you see what's around you, and you interpret.
One moment, please.
I tried to unmute all to allow the conversation, and I muted you. So give me a second. Let me go back to you. There you go, Ira. Sorry.
Sure. If it's easier, you can just ask questions in the chat, and I can account for them as I see them. Apperception is much more active. It is a looking for as opposed to just a seeing. But once you recognize that you're looking for something, or you're actively observing the situation around you, you also have to be very careful that you're not imposing your own biases or imposing your own desires of what you want to see onto the situation. We're going to talk a lot more about that as we go through, but the active awareness allows you to both be empowered to see, makes you much more engaged in terms of what your attention is, and it also makes you more able to recognize that not only are you seeing it a particular way, the situation, but there may be other ways to see it as well. Analysis then comes in terms of recognizing that you have salient facts and values. Those are going to be clinical facts, social facts, legal and moral facts, as well as organizational norms, priorities, and so forth, as well as values in terms of your own values, values of the collaborative care team. We all recognize that different professions prioritize values slightly differently based on their goals of care. And individual professionals might have different value priorities than the organization at large. That happens in many different organizations. So recognizing what the facts are and the values are of the various stakeholders will then allow you to analyze how to prioritize these different tensions through the different ethical frameworks that people use. Then once you are able to be aware of what's at stake and analyze how one would act, you would then, as a iterative process, recognize that it's not just a matter of ought, it's a matter of can as well. There's this logical statement that ought implies can, which also means that cannot implies ought not. So if you come up with an ethical decision that cannot be carried out, then that is not the decision that you should be advocating for. You should be trying to find the way in which you can be successful within the goals and values that you have. So we're going to go through this quickly in order to be able to get to the case. One of the things to recognize when we're first aware of something is that we all have gut reactions. Our gut reactions are not always correct, although they sometimes can be. The way gut reactions usually arise it comes from one, that we are emotionally and cognitively engaged, and two, we recognize similarities of this experience to previous experiences that we've had, either personally or vicariously. So in order to maintain consistency, we apply our previous experience and our previous knowledge to the case that we now see quickly. However, when we do that, we also know that there's going to be a framing issue. Now, when we frame something based on our previous experiences, we highlight certain facts, while at the same time fade out those facts that may be relevant but are outside of our frame of reference or outside of our frame of understanding. So what I advise is that you shouldn't say gut reactions are bad, that they allow us to make too quick of decisions. Gut reactions are actually really very important in ethical decision making because it allows you to start both with something concrete to work with, to analyze, but it also allows you to start checking and understanding from where you're approaching the question, right? If you recognize that your immediate reaction to something is because it's evoked by something else, whether it's a bad experience you've had, your bias towards a particular value over another one, whether it's emotional, cognitive, or axiological, it allows you to use your gut reaction to check yourself to make sure that you're incorporating all the data that's necessary. Any questions, by the way, with regards to gut reactions and apperception and awareness before I move on? No? Okay, good.
Good.
So once you realize that, okay, there is a lot of data here, like ethics should not be necessarily seen as a big question, but more in terms of pointillism, like the artistic form, where big questions come up or are made up of very small particular details that as you come up closer, you may lose the picture and get better access to the detail or the points. And when you step out, you lose the points, but you get a bigger view of the picture. You continually in ethics or ethical deliberation go back and forth to make sure that the particulars and the general come back together. So with regards to analysis, the first question you're going to ask is, why does this issue matter to you in your team organization? what relevant facts and values does it speak to? The second is, and this is what I recommend before anything else, and it's a different technique than most ethicists have. Most ethicists say that take the relevant facts and values and then apply an ethical framework to come up with a solution or to come up with an ethical decision. That way you can know that the process is good, and if the process is good, you know your decision is good. I actually recommend that you come up with as many choices and alternatives as possible, even bad ones, because this will do a few things. If you look at all of the possibilities of how you can respond to a situation, then you can recognize, one, that there's more than just one answer, even if some answers are better than others. So you're not constrained by framing your question of, is it okay to do this or not? It empowers you to be creative in looking for solutions that you may not have thought of before. And then it also allows you to think about those choices through the ethical frameworks in such a way that it doesn't make presumptions of understanding. So if you want, I can give you an example for this. You guys want an example? Yeah. Okay. So let's take the example that I wrote in the CNN article about allocation of resources. I think that's a really good one. The ethical problem was that there's not enough resources or there may potentially not be enough resources to save everybody or give everybody a ventilator. So we need to find the best choice or the right answer in order to be able to make a decision of who should get a ventilator or not. That's not a technical question, that's an ethical question, because the answer isn't simply provide more ventilators, which would be a technical answer, because there weren't enough, or the assumption was that there wasn't going to be enough. So there was going to be a conflict of values or a complex adaptive challenge to deal with. So a lot of ethicists said, all right, well, this is a public health frame, not a clinical frame, so let's just use a utilitarian framework of maximizing the greatest good for the greatest number of people. So again, going through the process, everything now seems coherent. So they then continue and say, all right, well, if we're going to maximize the greatest good for the greatest number of people, which means maximizing the greatest number of lives saved, it's coherent to say, well, lives are made up of life years. So therefore we should maximize the number of life years, right? That's a natural step. Not saying it's right or wrong. I'm just describing what was happening. So therefore, if we're maximizing the number of life years, then it seems coherent within a consequentialist frame to prioritize younger patients over older patients, not because of comorbidities of older patients or contraindications or clinical reasons for older patients, but simply because we want to maximize the number of life years, which maximizes the amount of life, which gives the greatest good, because now life is deemed as good to the greatest number of people. Right? That seems coherent. And it also seems that the answer is a natural choice from the process, almost as if you can come out with no other choice, right? In terms of the coherence of the argument. Does that seem normal?
Yes.
Yeah, okay. So now someone, the last time I gave that example said, yeah, but look at a deontological frame, you're not treating people as this, whatever. And I'm like, let's not go to a different frame for a second. Let's even say within the same frame of consequentialism or utilitarianism, let's see if that is the only option that can come up. It seems like it naturally would be the only option because I took through the steps and it seems like everything worked. But let's see. So I gave another example showing what assumptions were being made, where the other example was take a 65-year-old who has the same prognosis or survivability as a 20-year-old. However, the 65-year-old supports 3 kids and 10 grandkids financially. And the 20-year-old is self-sufficient with no family. Could one then make an argument that the 65-year-old, if the 65-year-old were to survive, then there would be greater support and more maximized life years because of the support that 65-year-old gives to the kids and grandkids over the 20-year-old. Now, again, that's a maybe, maybe not, right? But what that does recognize is that the previous consequentialist thought process assumed that people live alone and in an atomized way, without connections and interdependence among themselves. Right? So while it seems coherent, it, without intention, maybe intentionally, but at least not explicitly, had certain assumptions that weren't being considered. Right? So when you think of as many choices as possible, it not only allows you to analyze it, but it also allows you to think about the subtext or the assumptions being made that don't come out when you go through the one direction of going through facts, values, through process, through choice. Right? So that's why I recommend doing choices first. Even bad choices will allow you to determine why it doesn't work, which can inform the other choices. Then, as opposed to seeing things as, well, it's either this or that, or it's either, this is either good or bad with nothing else, or no alternatives to work with. So let me go through quickly some of the frames of reference for ethical thinking, not in order to give the philosophy behind it, but just to know what's at stake when thinking about how to approach an ethical decision. So deontology basically is a process-oriented approach, which means that your duty or that which you can control is that which is morally relevant. That which you cannot control, or the consequences in a complex situation, is not something that is factored into. Right? The second is that the choice that you make needs to be universalizable, which means there shouldn't really be any exceptions or particularities. Now, of course, if I see someone who's having a heart attack in a movie theater, what the decision I make and the decision you would make, because I'm a PhD, not an MD, I just want to make that clear, will be very different, right? Like, I will call a doctor. You will save the person's life. But the duty we have is exactly the same in terms of making sure we do something in order to save the person's life, right? It's not that the decision is particular. The decision is universalizable. How we accomplish it is based on our own particular skill sets and abilities, right? The third aspect of deontology is that intention really matters, meaning you could do something that complies with the moral imperative and still not be moral. The example that I give is, if I see an old lady crossing the street, I can either help her because it's the right thing to do. I can help her because I want to impress my peers, or I can help her in order to steal from her purse. Now, I hope we would all agree that stealing from her purse is not moral. Doing something to impress one's peers may be seen as a moral act or comply with the moral law, but shouldn't be seen as moral in and of itself. Now you ask me, like, who cares? Like, if the good is being done, what difference is my intention? So I would say from an ethical perspective, it may not be much. From a moral psychology perspective, it's going to be a lot. And just to give an example that's very relevant to today, if you want to go to the hospital to save COVID patients in order to impress your peers, or in order to get certain accolades, versus doing it because you think it's your moral duty, if it gets difficult to do so, or if there's an easier way to get what you want, which is the accolades and the social esteem, then you'll do that, right? So intention speaks to your level of commitment in continuing when something is difficult. Now, I'm not saying that just when something is difficult, that means you should always do it regardless, but it allows you to ask yourself when you're making a decision, why am I making this decision? How persuasive will I be both for myself and for others in carrying out this choice? Is this choice I'm making empowering me to do something? Or is it that I believe I should do? Or is it empowering me to do something as an indirect way to get something else that I want? Right? Those are really good questions to ask when creating ethical policies and looking at ethical decisions. Right? Even in ethical policies, if you're trying to change habits for the sake of something else as an indirect, there's a less the chain of cause and effect is not as tight, and you may have unforeseen habit change that is deleterious to what your original intentions were. Consequentialism, and I just gave the example for resource allocation, really, I mean, we all know about it. I mean, it's the most economic, quote unquote, in terms of maximizing and minimizing harm. The two things to really consider is that your terms have to be really defined. Good is an equivocal term. For us to say, we want to maximize the amount of good for our patients without defining what good means that we'll either have a ambiguous or fuzzy action plan, or if we're trying to work with a collaborative care team that has different conceptions or definitions of what good is, we're not going to come to a consensus because we're speaking past each other. The second aspect of consequentialism, which is really important, and by the way, this next point actually will go to the case that we talk about too, is there's a big difference between act utilitarianism and rule utilitarianism. So in case you guys aren't aware, act utilitarianism basically means let's do the best thing possible for this situation. Makes sense. Rule utilitarianism means if we acted in this situation every time it occurs, either for every person that occurs or every time it occurs for this particular person, will it still maximize benefit, or are there now unforeseen harms by virtue of the repetition? So an example of this that we all are aware of is a patient comes in, has a cold, you don't know if it's a virus, might be a bacterial infection, you have no idea, right? You say, all right, I can give you an antibiotic, and if it works, great. If it doesn't work, well, the virus will run its course and you'll be fine. Patient's happy, everyone's happy. Seems to be the best case for the situation. However, if you did that for every patient, then they'll have a development of resistant strains. Then you'll have problems with regards to future bacterial infections. The amount of repetition of doing what's best for the moment may have an overall detriment when repeated over and over again. So when thinking about what to do in the clinic versus how to create a hospital policy, you need to look at the difference between, is this right for the moment or is this right at all times? Principlism is the last frame that I'm going to go through. And then I'll speak quickly into action, but we'll go to Sidra to make sure that the case goes. Principlism, basically what it does is it says, I want my cake and eat it too. I like deontology in terms of thinking about process and knowing what the right thing or the right procedure would be. I also like thinking about consequences and trying to get the best solution, right? So if you notice, every time we try to throw ethics into a principlist frame, we come up with something called an ethical dilemma, where all answers seem bad, and we're trying to pick something that might be minimize all the dilemma because something's always at stake, and we defer to patient autonomy. Right? The reason why that happens is because respect for autonomy and justice are deontological or process-based values. Non-maleficence and beneficence are ends-based or consequence-based values. So you feel like you have to choose between a good process or a good outcome, especially when you look at relevant facts and values thrown into this framework of analysis. Right? However, principlism can apply in a much easier way that speaks to what we're trying to accomplish. If you instead do what I suggest and say, look at all of the choices that are possible here, you'll realize that your choices, given these value frames, will fit more like a Venn diagram. There will be certain choices that are strictly process-oriented. There'll be certain choices that are consequence-oriented. And then there'll be certain choices that both relate to consequence and relate to process, right? Just as like that intersection in a Venn diagram. So now instead of seeing it as a dilemma, you can see it as a way of minimizing the plethora of choices to a few significant ones, and then maximize or choose the best choice given the intersection. And in that way, principlism could work a lot better. But you can't take principlism forward. You have to use principlism backwards by starting with the alternatives first. So just real quick in terms of action. Now, action we talked about, it has to speak to your personal capabilities. It has to speak to your organizational posture, like where you are in the collaborative care team and the health system. most importantly about action is you should try to recognize, one, that your decision, you have a reason for doing it. You're not rationalizing status quo. But more importantly, you should realize that you can't do anything alone today. Healthcare is too complicated, and you work on a team. So in order to recognize that you want to do and advocate for the good and the right decision, you should think about who are your allies, who agrees with you, who doesn't agree with you. Those people that don't agree with you, do they not agree with you because they're rationalizing status quo? They can be persuaded. If they can be, how can they be persuaded? Or do they have insight into something that you haven't thought of yet? Are there hospital policies? Are there professional codes or professional guidelines? Is there healthcare law that benefits your point, and you can rely on those to strengthen your advocacy? And when I say advocacy, I really mean like being persuasive to make sure that the decision that, or the values that you want to project in your choice are ones that everyone buys into. Or are you looking to do something that really goes against all professional policies, hospital codes, and law? And if so, are you wrong? Like, thinking about the how can I accomplish this should serve as a further check of, is what I want to accomplish right and good, right? You're tying always the what is the right thing or what is the good thing with how can I act on my choice in a way that's successful. Just as ought implies cannot implies ought not. So we're going to look at the case that Sidra's going to bring, and we're going to see if we can think about what are the salient facts values that come up in the description of the case, and what are the choices that are available, and how those choices could be carried out in a way that speaks to the patient, speaks to how to communicate with the family, speaks to does this fit with the allocation of resources that the hospital is considering, and how can the choice that we decide is the right and the good one can be carried out in a way that doesn't alienate collaborative care team, alienate patients, alienate family members, and create a situation that's oppositional or antagonistic rather than one that allows for shared decision making. So I'm going to stop here because I spoke for a long time, and we're going to go to Sidra.
Okay, so coming to the case. All right, so the case that I will be presenting is of a 81 years old female that was brought into the ED after the family called 911 as she was found to have altered mental status and she was short of breath. At the time when the paramedics were at home, she was found to have like a fasting blood sugar of 26. They gave her glucagon, they gave her D10, repeat sugar was still low. She was also found to be hypoxic in the 80s, and they had to put her on a non-rebreather. She was very minimally responsive when they brought her to the ED. In the ED, she also tested positive for COVID. So the initial triage vitals that were noted by the nurse, her blood pressure was okay. She was slightly tachycardic, but she was very hypoxic, requiring non-rebreather. Initial exam was she was minimally responsive, though still protecting airway. She had dry mucous membranes. She was wheezing. She had bilateral pitting edema, had distended abdomen, also had some ecchymosis over the extremities. So looking at her presentation, the family was called, and after the physician spoke to the daughter, the situation became more clear. So as per the daughter, she was recently admitted to JFK Hospital in March for diverticulosis, and she was diagnosed with liver cirrhosis. At the time, they discharged her to a rehab facility, and then in the rehab, she developed COVID symptoms. So she was again admitted on April 8th with like COVID pneumonia. She stayed in the hospital till April 20th, and at that time, as per daughter, the doctors told her that there was nothing more that they could do to help the patient, and that hospice was probably the best choice, and then with the goals of keeping the patient comfortable. So she was sent home on hospice on April 20th. She was at home oxygen, she was on a morphine drip, and she was getting Ativan PRN. 2 days later, the daughter became really upset with the home hospice as she was seeing that her mom had difficulty breathing. She had like oral secretions, she was not eating, she was febrile, and so she did not want her mother to die, so she called 911. So at this point, like once the discussion, after the discussion with the daughter, it was very unclear if the family understood what actually hospice was, and that her mom was actually dying at home peacefully, which was the initial plan. The daughters wanted her mother to stay full code, despite her understanding that she would have her past medical history. So diabetes, hypertension, dyslipidemia. She had like sacral fractures, liver cirrhosis, family history non-contributory, her medications. So she was on a bunch of medications. It's not sure if she was being given all these medications when she went home on hospice, but these were the listed medications on admission. So this is her initial chest x-ray on admission. And at this point, she was on a non-rebreather and satting close to 100%. Her initial labs, so her white count was within range. The hemoglobin was initially 9.2, and then it dropped over the course of few days to 7.4. The platelets similarly also dropped from 61 to 15. Her PT was high, her fibrinogen was high, the D-dimer also started trending up. So all the inflammatory markers started trending up. CRP went up, LDH was to 95, ferritin went up. So overall, she was getting worse by the day. This is her initial CMP. Her creatinine eventually did trend up to 1.6. So while in the hospital, she initially received the empiric antibiotics. She was given like D50, multiple pushes, started on steroids while she was in the ED. She was admitted to the medicine floor. She was deemed not a candidate for remdesivir or tocilizumab due to her liver cirrhosis. And 6 days after admission, she had worsened hypoxia. And at this time, she was on both non-rebreather and high-flow nasal cannula, saturating maybe like 90% at most. And so a MICU screen was called. So her X-ray at that time obviously shows worsening bilateral infiltrates. And at this point also, there's like ongoing goals of care discussion. The palliative care team were on board right from admission. So it's like daily discussions with the family as to how they would want to proceed. So then the inevitable happened, and then she got intubated on day 6 of admission. She was in a severe ARDS. She currently is still in the hospital, so she continues to require vasopressors. She is off all sedation, but still has is encephalopathic. She also developed Klebsiella urinary tract infection. She has worsening kidney function, and also has other complications like pneumomediastinum. So now the question is that the daughter feels really annoyed because multiple physicians have been bringing this question up to her, bringing up the question of code status and how aggressive should her care be. She wants to continue all measures because she believes in miracles. To facilitate this process of helping family make decisions, the primary team has been utilizing FaceTime so that family can see the patient and keep themselves in touch with the patient. So this patient still currently is in the hospital, and these goals of care discussions are ongoing, and she continues to require all aggressive measures. I would like Dr. Bedzow take over and then discuss this case further.
Sure, thank you, Sidra. So, I mean, I have a gut reaction on this case. For the sake of practicing skills and so forth, would anyone want to tell me what their initial thought is on this?
Everybody's on mute, so we'll wait. We'll get the feedback from everybody at the end.
All right, fine. So look, my gut reaction. Sometimes.
Sorry. I have a comment from somebody. So
sure.
Somebody said, I noticed her first X-ray, she was wearing rosary beads, and so this person would tap into her religious goals and thoughts.
Yeah. So that is first of all, that is a great perception. That is a great perception, and I think that's something that needs to be considered. I would say that for me, my gut reaction initially doesn't, for me, just because by virtue of my training, my gut reaction usually comes out as a question more than it comes out as an answer. So that my initial question is, I don't understand if she was already with home hospice. How does her family want to continue care and have all treatment measures? What happened there in terms of what the disconnect is between what the patient was currently being cared for and the family's request for treatment? Okay. David, you're on mute.
There we go. Another comment saying, depending on the faith tradition of the patient and family, the miracle, the quote miracle, would be the turnkey to, and then explore what they mean by miracle. Yeah.
I mean that fits. So all these questions are going to come into what the stakeholders, right? So look, my gut reaction immediately was like, I personally have a hard time saying no to people. I would want to do what the family would want, but I also recognize that if someone is put in home hospice, that means they recognize that they're to be kept comfortable, and we're not trying to cure anybody. I also then have the question of, well, is putting someone on a ventilator, could it be categorized as care and not treatment? Because we recognize that with COVID, at least, there's no cure for it, especially ventilation is not a cure. And how am I going to communicate to the family members in such a way that recognizes both their values and their religious beliefs? The previous seeming decision of the patient, whether it was through proxy or not, of wanting hospice versus continued treatment, and the hospital's organizational policies of, which I'm sure the hospital is already thinking about, was understanding what resource allocations may be at this moment in terms of who to even give treatment to, knowing that there's been lots of discussion in the news and otherwise about potential scarcity of resources. All right. So I would already start gathering my questions and my facts and my thinking, so forth. Then I would go.
Sorry, there was a comment about hospice, and this might even predate this hospitalization. But many families agree to hospice, but don't truly understand its goals, and so explaining futility of certain measures can be exceedingly difficult. And I'd say, add to that, the alternative or the opposite can also be true, that many families don't agree to hospice because they don't truly understand its goals.
No, of course, and this is, I think, where the biggest disconnect is in this case. The question, I don't think, I mean, it is a question, but it's actually, I think, a secondary question. Isn't, well, should I treat the patient or not? In order to know whether one should treat the patient or not, one also has to figure out why the patient was put in hospice in the first place. And are the patient's family members changing their mind or not? Because we all know, with regards to acting out our decisions, and having a difficulty in terms of making decisions that go against angry family members, that it's very hard to do. And we're not going to want to rationalize a decision because we want to be conciliatory, either for the sake of minimizing hospital risk, potentially being insecure with the decision that we make, and deferring to life or deferring to the family's wishes, because we have physician integrity also. So I would look at this case as much as the ethical question is, why is there a disconnect between the patient's current course of care and the family's current request for care? And not simply looking at the first question be, okay, well, do we treat the patient or not?
And then also comment that it may help to change the conversation not to what the family wants, but what they think their mother, the patient, would want. And so reframing the conversation can often result in a different perspective.
No, of course. And if you think about it, if this goes back to why the patient was in hospice in the first place, right? If the patient, like, if it's what the patient would want, and the patient's had either made the decision or was made through proxy because it was based on substituted judgment standard that she should go to home hospice in the first place, then what the family is asking for is a change without any indication that the patient would have wanted that change, right? If the family member was put in hospice against her will, whether that will was explicitly or made or in a subjective standard or substituted judgment standard, that's a very different understanding of what the ethical question is, right? So from the first thing in terms of awareness to analysis, before going to the big question, you even have a smaller question of where is this disconnect? If the mother is Catholic, as you see by the X-ray, and in the Catholic community which she's in, there's a very low incidence of people using home hospice. That's also something to consider in terms of stakeholder values and priorities and so forth. A question like this, I'm not going to say what the answer should be because there's so much detail that needs to be considered and analyzed. But in terms of the ways of having a thought process here, the thought process is first frame in terms of why is there a disconnect in requests for care. The second frame is once that disconnect is resolved, is further treatment in the patient's interest based on the patient's wishes. And the third frame is in a situation where there's potentially scarce allocation of resources, is it still possible, and I think given where New Jersey has been, it would be anyway, is it still possible to provide the patient the care that they're requesting, knowing that it's actually what they're requesting, knowing that's in line with their values? So I would actually break up this big case into three specific questions to ask or questions to answer and decisions to make. Each of those being, a relationship between deliberation and the how-to kind of process strategy.
There's a question here for Sidra, that there's a thought fairly certain that with PAL care already involved, that some of these disconnects may have been explored. So can you shed some light onto this and maybe discuss what was or was not discussed between PAL care and the family? And are these discussions feasible? It may lead to some more actionable ideas in this case.
The palliative team felt that the daughter did not have a good grasp of what hospice really meant. What she took for her mother being comfortable was that she'll be cured and then also comfortable at the same time. And at the time of the initial palliative consultation, she kind of realized that yes, her mom was actively dying and that her prognosis isn't good. But I think when she made the original decision to make her hospice, I don't think she clearly understood what hospice meant.
Okay, there were a couple other questions that came up more broadly about bioethics. And what I'm going to do is I'm going to, maybe Sidra, you can end sharing your screen so that people can be seen. But some other more broad questions about bioethics. And so, Ira, you touched during your talk about basically valuing different individuals in how much care or the type of care we provide. And you talked about using age or number of years left, or number of family members that somebody might be caring for. And I think in Spain, they actually used social worth as a way of determining who would get different forms of care, such as limitations on ventilators. And so, one thing that was brought up there that thankfully we haven't had to decide about here was, if somebody comes in and they both take care of the same number of people at home, they're both the same age, but one is an ICU physician or emergency room physician, and the other one is not necessarily an essential care worker. And the ethics of giving preferential care to one person who may have more social worth than another person.
Yeah, I'm glad that came back around as a question, because one of my fears I had was that you take the example that I gave as what I was endorsing, as opposed to just showing that the difficulties about it. So I think that it's very difficult to take social worth, years left, or potential years left, or any type of social factors into consideration in these types of allocation of resources for a number of reasons. One, I don't think that healthcare has the moral authority to make social determinative decisions. I don't think that the profession's ethos or moral foundation is to treat patients contingent on how beneficial they are to society or based on a societal definition of good. I think that the profession's duty to treat is to treat vulnerable patients based on their clinical and their medical conditions. So the first thing in terms of determining which social worth is better than the others, that is not the role for the medical profession. I also think that our society, we'll start with our society, is so multicultural and so multifactorial that to impose one group's values of what social worth is will immediately create a problem in terms of imposing power dynamics or cause more difficulty in terms of the equality of citizens to the point where it's almost like an Animal Farm situation, where we're all created equal, but some animals are more equal than others. So I think it's very difficult in looking at allocation of resources to say everyone's equal and should get treatment, but if this person comes in, they're more valuable and we should treat them first. So then you're stuck with, okay, well, what do I do? Right? So historically, there have been, besides looking at social values, there have been a couple of other alternatives, like first come, first serve, and lottery. First come, first serve was originally in favor. Now it's not in favor. Lottery still isn't in favor in a lot of places. Intellectually, it's harder, I think, because intellectually, we can think of many cases or set up the case of everything's exactly the same, but I don't think that is so often the case in reality. I think that it gets harder and harder, like people get closer and closer. But I think in situations like this, we have to be very careful of the difference between making a decision that's difficult and making a decision that's clear and easy and wrong. When things are really close, then from an ethical perspective, I think that the frame can't be, I'm killing a person. I think that the frame needs to be, and I'm saying when it's really close, clinically, like everything, that I can only save one person. I have to, like, one person will be saved, not one person will be killed. Because if you focus on the mistake or the negative side of it, you're gonna have moral distress to the point where it's gonna cause trauma. It has to be framed in the sense of all things being equal, a life is being saved. But to say, well, I'm afraid to make those decisions, so I want to dump on society to tell me how to evaluate people socially. From a consequentialism perspective, you may say, okay, like that does the best in the moment. From a rule consequentialist perspective, or from a global perspective, not only will you be damaging your own physician integrity, but society will suffer as a whole from it, from all of the consequences that will come in systematizing those types of differences. Is that an answer? Is that okay? David, you're muted, so I'm assuming you're just saying great things.
Nothing but the finest. Yeah, I mean, I think, you talked about gut instinct, and I think that everybody would agree with you cognitively and even emotionally, but in the moment when you're faced with theoretically two exactly the same patients, and one of them is a colleague, your gut instinct is to take care of that colleague or somebody you at least identify with more than the other person.
100%. So let's talk about this, right? One of the reasons why a lot of ethics policies in different hospitals say that just how you have a triage committee that's separate from the end of life discussions committee or end of discussions life team, you should have a different ethics committee to make these types of choices in order to not account for those types of emotional attachments. That is a systems idea, and that's not deferring to ethicists to make decisions for you, but it is mitigating the closeness between the person making the decision and the person carrying out the decision, right? So this is also something to really consider. Is the moral distress that a person faces, does it come from making the decision or carrying out the decision? So I'll immediately answer, both are affected. However, you have greater moral distress when you both have to decide and carry out. If you trust that the decision is the right one, even if it's hard for you to carry out, you will have less moral distress because you know that you did something hard, but not necessarily something immoral. Right? So that's a systems alternative for a individual problem.
Thank you. There's another question about basically protection and minimizing infectious risk, and knowing the balance of taking care of the patient versus protecting and minimizing infectious exposure to other patients and to hospital workers and to society. So how do we balance, our instinct is to sit down on the patient's bed, hold their hand, counsel them, spend as much time as possible, do a physical exam so we know, so we can tell more about the progression of their disease. How do we balance our duty to do that with our duty for the greater good of the ward or the hospital or the nurses or ourselves to not go into the room at all and just talk to them over the phone?
Yeah, so look, you realize the way you asked that question already started to answer it. Because you didn't ask, should we do something? You recognize that there is a clinical benefit as well as a psychological benefit to having interactions with patients. And the closer an interaction, the stronger the sense of care, the better it is both for the physician and the care team, as well as for the patient. So you're not saying it's an either or, either we give this and suffer or take it away and suffer. You ask, how can we do it? But now that's not an ethics question, that's a practical question. What can we do? What's available to us? What options can we go through? How far can we be? How close can we be? Come up with a ton of choices and see what the best ones are, right? How do you use personal protective equipment most effectively? How do you engage both technology resources and personal risk to be able to give that type of connection? Maybe people who are less vulnerable move closer to the patient, and those who are more vulnerable don't. Move further away. The how of it is going to be specific to the particular instance, who's available, what the hospital is, what types of patients you have, the level of risk, and the level of protection. It's not an ethics or a theory question. That's an implementation science question. You know. So again, like, ethicists are great at the non-answer.
I'm waiting a minute to see if there are any other questions. If anybody has any questions, please submit them in the chat. But in the meantime, I want to thank, I know that, you know, we are all very busy, and that's no different for Sidra and Ira especially. So thank you to both of you for joining us. Thank you to everybody who was here and all the fantastic questions. And we'll see you next week for our next Grand Round session. And we'll see also many of you at 1:30. We have our Department of Medicine faculty meeting. So thank you very much.
Thank you, everybody. I hope you guys enjoyed and potentially learned something. So I appreciate it.